I work for Wits University, the University of Witwatersrand, and I've been involved in the treatment of drug-resistant TB for the last 10 years. What I want to do today is to talk about the history. That's going to be quick because the history is dark and it needs to be changed. And then I'm going to talk about the new WHO guidelines. And then more specifically, I'm going to talk about what it means to be a clinician treating people with drug-resistant TB. In this room are most of you clinicians. So you're seeing patients. And I find that we need practical advice on how to implement the WHO guidelines. My talk is going to first of all cover a short history of the older guidelines. Don't worry, you won't fall asleep in that one because it's going to be very short. Then I'm going to talk about how the STREAM trial fed into the 2018 guidelines. I'm going to give a quick overview of the STREAM 1 results and then talk about the latest guidelines that have been produced by the WHO, and the ink is still dry, they are still very new. I'm going to talk about new drug regimens and what the future holds for us. Just a little bit by way of a background. As Ivan said, I'm from South Africa. In South Africa, we have 15,000 cases of drug-resistant TB started on treatment every year. We're probably missing about 4,000. Our HIV co-infection rate in TB patients is about 50%. So if you've got TB in South Africa, half of our patients have HIV. So anything that's going to work in South Africa has to take into account if it works in an HIV positive patient. So from that premise, I'm going to start. These are the old guidelines. I think that maybe Moses took them down because they're so old. But the two things that I want to stress on this particular slide is that for the guidelines that came previous to 2018, they were all based on very low quality evidence, and they were all conditional recommendations. What is the highest way of generating, what is the highest level of medical evidence? How can we say we can be sure about medical evidence? Exactly. And even more specifically than that, randomized controlled clinical trials. That's how we know if something works, if it's been done in 1 or 2 randomized controlled clinical trials. And that's the highest evidence. Prior to the initiation of STREAM, there were no randomized controlled trials for the treatment of drug-resistant TB, which I think is bad. It's wicked. So remember the old standardized regimen that we used to use just a mere 2 or 3 years ago. We treated our patients for 20 to 24 months. We used a quinolone, usually moxifloxacin. We used injectable agents for a minimum of 6 months. Those are painful and they cause about half of our patients to go deaf. PZA, not sure if it works. Ethionamide, it's a terrible drug to take. Patients complain almost continuously of nausea and vomiting. Cycloserine and ethambutol, and then after that we continued the treatment for about another 18 months. My patients who were treated with the old regimen told me that the treatment was worse than the disease. That they wouldn't wish multi-drug resistant TB on their worst enemies. So what would happen is that they'd get better in the first 2 to 3 months because they were controlling their TB infection, and very shortly thereafter they would start to be sick from the drugs that we were giving them. And it's no great surprise that many of our patients were lost to follow-up. They just could not manage to take the medicines we asked. So in 2010, Armin van Duren did a study in Bangladesh, that's why it's called Bangladesh Regimen, looking at a shorter course of treatment that included either Loxi or Gatti, still an injectable agent, usually kanamycin, PZA, ethionamide, high-dose INH, clofazimine, and ethambutol. So that is the so-called short course. And then, as you have stated, the highest form of accumulation of medical evidence is a randomized controlled trial. And out of that, the STREAM trial was born. So what was the STREAM trial? or is the STREAM trial? Ishmael, I have to remember the present tense. How are you? So in the STREAM trial, what we did in STREAM stage 1, we compared the current guidelines in a country for the treatment of MDR to a modified 9-month regimen like the Bangladesh regimen. The reason we call it modified is that instead of using gatifloxacin, because gatifloxacin is not available anywhere in the world, it's not being manufactured anymore, we used a high-dose moxifloxacin. And in STREAM 1, those two were compared. STREAM 1 has a sister, or a brother, I'm not sure, called STREAM 2, and I'll cover that very shortly. But in terms of the results of STREAM 1, remember, if we're going to accumulate evidence, I don't want to know whether it just works in Malaga Hospital or just works at Caesarea Hospital, the hospital that I work. I want to know, does it work in all populations in all countries? There's a difference between countries. HIV prevalence, the resistance patterns that we see, genetic makeups of our patients. So STREAM 1 was conducted in a number of sites. There were 2 Ethiopian sites, both in Addis, 3 South African sites, and was also conducted in Vietnam and Mongolia. And the question that we asked in STREAM 1 is the 9-month treatment as good as a 20-month treatment, and that the study design is called a non-inferiority study design. And the results were surprising to me. And that's because in South Africa, in our NDR program, our success rate, success is a combination of treatment completion and culture conversion, was 50%. So I thought anything above 75 I'm happy with. But the results of STREAM 1 were a surprise to me because the first thing is that both of the regimens, the short and the long, performed at a very high rate of about 80%. I think part of that is because we chose, well, the trial investigators chose good hospitals with good support, and also a clinical trial is generally overcapacitated. We had 2 or 3 study nurses, 2 study doctors, so we had, and counselors, and we had the ability to trace our patients, and very few were lost to follow. So statistically speaking, about 80% in both arms had a successful or favorable outcome. So it means they probably are comparable. And there was also no evidence coming from a South African background that it was any different in the HIV positive versus negative individuals. So, but on the other side, the rate of adverse events was about the same as well, whether we used short or long. That was another thing that surprised me, because I thought that if we gave the treatment for a shorter period of time, we'd see less adverse events, but we didn't. So in terms of the rate of serious adverse events, which are grade 3 or 4, or grade 5, is actually a death. They were the same between the two. The most common adverse event that we saw were cardiac disorders. An increase in the QT interval, which we know can be a forerunner of a sudden cardiac death. So that was the most common. Hearing loss was recorded in about 5% of patients. However, we didn't do formal audiometry. So hearing loss in patients with drug-resistant TB, by the time a patient tells you they cannot hear, they're already significantly disabled because it starts off with high-frequency hearing loss. So the answer is yes, short and long are about the same. Then to expand the clinical trial network, because we'd established clinical trials in the sites that I mentioned, and then also to expand it even further, we started with STREAM 2. So the sites were expanded to some sites in India, the Ugandan site that is recruiting like a steam train, and Mongolia, Moldova, and Georgia. These countries are in Eastern Europe, and there is a slightly different distribution. HIV is virtually unknown in Eastern Europe. However, the rate of XDR and pre-XDR is much higher in Eastern Europe. So again, we wanted a little bit more background. There's a new kid on the block, and his name is Bedaquiline, or her name, because I think she's powerful. Bedaquiline is the first new drug that has been registered in my lifetime. I qualified in 1989, And just to sort out the maths, I'm 54. And what we wanted to know was, can we combine bedaquiline into a regimen? There's not going to be one drug that treats drug-resistant TB. It's always going to be a group of drugs. And what we need to do is to say, we've got some new people, some new drugs on the block. Let's see how we can fit them in and get an effective regimen. And we wanted to know how we could do that. So one of the arms in the STREAM trial is a fully oral regimen. I don't like injectables. I don't like having to give them. I don't like the side effects. So we want a fully oral regimen. And we want a simpler regimen containing bedaquiline. They've had to be modifications because it's been slower to recruit than we thought. There were 4 arms, but some of them had to be deleted, had to be removed. And so Arm A, so the long course, is virtually out in every single country. And then because we don't like injectables, we had to drop Arm 2. But so based on that, we've got the first randomized controlled clinical trial ever. Fortunately, things are moving. That gave us information on how to treat our patients with drug-resistant TB, and in particular NDR only. Any further resistance over that, so resistance to an injectable and or a quinolone, is not treated by this regimen. So for the first time, the WHO guidelines were rewritten, and these rewrites occurred in 2016. And what they did is that they recommended the short course regimen, it seemed to be a potential better treatment, and it was endorsed by the WHO. Believe me, this was a very difficult thing to do. The old classification of drugs looked at, first of all, the fluoroquinolones, the second-line injectables, and then other core drugs. And the things that I want to point out, if you can see this, is that there are a couple of drugs that were either a C or a D. The ones of note is linezolid was a C, meant that if you could use it, it was probably okay. And then look where bedaquiline was in the old guidelines. So the old guidelines were, if you really have to, you can add it. I'm making it a little bit shorter, but the bottom line is that the old guidelines, that's where those drugs were put. And that wasn't long ago. That was only two or 3 years ago that the WHO classified the drugs in that way. But the short course and the long course, they are just variations on a theme. So we're giving the same medicines with the same side effect profile, and we know it's the same from the randomized controlled trial. We know that the adverse event rate is the same. So we're giving a similar kind of thing. We're still giving injectables. We still have toxicity concerns, and we needed to do something that was innovative and brave, something that is different from normal. And what we came up with, well, not we, because I'm not part of the WHO, but these were the new guidelines that were released this year. So the new guidelines basically give us 2 options. And I'm going to kind of unpick them and go through them so that we can think about how it would be useful in our context. I'm a South African, and in the Ugandan context, to use these drugs, and how to rewrite the new guidelines. In South Africa, we've had political resistance to changing guidelines. We just changed the guidelines, and now we want to change the guidelines again. And believe me, in 2020 we will change them again, or maybe 2021. Things will change again. So we've got to get used to this kind of change. We're used to it in HIV. In HIV, we started off with you only treat with an AIDS-defining condition, and then we decided CD4 count 200. Now we know universal access to antiretroviral therapy is the way to decrease morbidity and mortality. And we've got beautiful new drugs in HIV. Dolutegravir, I believe, is being rolled out in Uganda. It's a wonderful drug. It's got very good interactions with other drugs, particularly my friend bedaquiline, and it also has a very low side effect profile. So we're used to guidelines having to change. That's nothing new. But I think because the TB guidelines are so slow to change, that the politicians have battled with this. So in the guidelines that have recently come out, they give our patients with NDR, and I'm stressing NDR, 2 options: a long regimen and a short regimen. The longer regimen, and I'll talk about the drugs in a second, is a 18 to 20 month regimen, and it's all oral. Everybody agrees who treats drug-resistant TB, we don't want injections. We do not want them, they're a pain. So, and also they're not all that effective. And then the standardized short regimen, which is the one that was shown to be equivalent or non-inferior rather in the STREAM trial. But it's a very standardized regimen. There's no fiddling around. You can't change something if you want. You've got to give the whole package, or you've got to change altogether. Which, I mean, logically you kind of think we've got a long oral regimen, we've got a short injectable regimen, what about a short oral regimen? And the evidence for that has not yet been accumulated. Watch the space, it's coming quickly. So we are going to find answers pretty quickly. But what the WHO did, based on an individual patient meta-analysis, and there are lots of flaws in that study itself. They looked at patients who'd been treated for drug-resistant TB, and they looked at their outcomes, and they tried to pick out the effect of a single drug. Now that's intrinsically flawed. It's flawed because in cohort data you don't have as good information as you do in a clinical trial, and also a lot of the information was split between developed and developing countries. There's a big difference between a developed country and a developing country. One of the things is money. So if the drugs are expensive, we use different drugs. And a lot of the evidence is based on people who were in Eastern Europe. And last year, I think that there were about 36 cases of drug-resistant TB in the United States. It's not common in the United States. But it was, and there the doctors have huge amounts of resources to deal with the problems. But in South Africa and Uganda, we don't have huge amounts of resources. And we've got to use our money wisely. So the guidelines came up with this, this for the long regimen. The three top drugs that must be in every single regimen for somebody with rifampicin-resistant TB, no more than MDR, is a quinolone, either levofloxacin or moxifloxacin. It is still unknown whether levo equals moxi. So whether we can say they are equivalent drugs. They're obviously in the same class, but there has never been a head-to-head study where we've used moxi in one group and levo in the other. But what really separates the two drugs is the side effect profile. We know from the STREAM trial that 10% of patients who were given high-dose moxifloxacin had a QTCF, we used the Friedreich's correction, had a QTCF above 500. That predisposes them to a tachyarrhythmia. So it's the QT that is driving the change more to levofloxacin. Datifloxacin is off the list because it's in the same place as the tooth fairy. We can't find it. Then bedaquiline is a drug that was registered first by the FDA in 2012 and then registered by the South African regulatory authorities in 2014. There was a little bit of controversy in the original bedaquiline registrational trial. So what happened in the registrational trial for bedaquiline is that patients were randomized to get the optimized background regimen, so whatever the country was doing, and then they were given either a placebo or an active drug, and the active drug was bedaquiline. I was the principal investigator on that study. We recruited, I think, about 35 patients. It's quite a while ago. But it was a blinded study, so both myself and my patients were blinded, but I could tell with a fair degree of certainty which patients got which. The patients who got bedaquiline, and we were right, is that we were unblinded 2 or 3 years after the initial publication. So the patients who got bedaquiline, they got fatter quicker. So our skinny TB patients, they got fatter quicker. They put on weight. Their sputum cleared faster, and symptomatically they got better. So right from those early days, I knew this was a winner. But the problem with this study is that there was a mortality imbalance. It was a small study, and more patients who were given bedaquiline, and that was 11 patients to 2, died. Some of them died from TB and its complications. One of my patients died in a motor vehicle accident. He was not the driver, so it was totally unrelated. But because of this imbalance, there was a concern that the QT prolonging effect of bedaquiline may have been the cause for mortality. So there was always this little bit of a, we're not entirely sure if this is a good drug to be using. But based on my experience with the bedaquiline, I approached our national TB program and I said this drug has to be available to South Africans. And we initiated a program that is called the Bedaquiline Clinical Access Program that was initiated in 2014, where patients with extreme patterns of resistance, like extensively drug-resistant TB or resistance to a quinolone or injectable, were offered bedaquiline. We enrolled 200 patients on it. It wasn't a clinical trial, it was an access program. And the success rate of those, so these are patients who normally would have a really poor outcome. The success rate, which is treatment completion or culture conversion and sustained culture conversion, the success rate was 75%. In the first outbreak of extensively drug-resistant TB in South Africa, 52 out of 53 patients died. So now we converted it from that to a place when 3 out of 4 patients with extensively drug-resistant TB survived. And based on that, we incorporated bedaquiline into our national program, and it has shown a significant reduction in mortality. Significant is more than 50% reduction in mortality, particularly in extensively drug-resistant TB. The South African mortality rate of bedaquiline, I'm sorry to keep referring to South Africa, but I'm here to share my experience. The mortality rate was 20%. So 1 in 5 people died. 1 in 5 people were lost to follow-up, and the rest were successfully treated. Now, we've reduced that mortality down to 10%. It's very significant. So bedaquiline is a good drug, and it should be incorporated in every NDR regimen as much as possible. Then the third category A drug is linezolid. What's the problem with linezolid? Is it a toxic drug or non-toxic drug? It's toxic. It is a very toxic drug to be giving. If you see a patient with TB and anemia, do you want to publish in the British Medical Journal, or is that a common presentation? It's common. Because TB is a chronic disease, and then you put that on top of the other parasitic infections or nutritional problems that patients who suffer from TB may get, and it is a common problem. The linezolid suppresses the bone marrow, and also in data I will show you later, can cause a peripheral neuropathy. So it's a useful drug. But probably, I don't know how your patients present, but at least 1 in 5 of our patients have a hemoglobin below 8, which means we need to be worried about it. So those are the 3 category A drugs, or group A drugs. Then the 2 group B drugs, clofazimine, we know it, it's our old friend now. Clofazimine prolongs the QT, has a very long half-life, so it sticks around in the body for a long time, and it also causes skin hyperpigmentation. In fact, if my patient's skin doesn't go dark, I think they are non-adherent to medication, because it's in fact a dye. And the way that the dye works is it sticks to a whole lot of things, and one of the things it sticks to is the cells of the skin. Hyperpigmentation occurs in month 2 or month 3, and will only stop a couple of months after treatment is finished. You can help mitigate against it by protecting the sun-exposed areas, but it is a side effect that bothers South Africans quite a lot. They don't like it. In patients with a white skin, they look like they've got a tan, except for it's like an orange tan, like the color of these curtains, so also not very popular. So clofazimine's our old friend. Tirizidone or cycloserine. I was quite surprised that it was bumped up this high, because I don't like the drug either. It makes my patients go crazy. And when I say crazy, I don't mean a little bit. We've had a patient who actually successfully committed suicide in our hospital. So patients become overtly psychotic. And when you add that to any CNS disease associated with HIV and efavirenz, it's a mess. But however, cycloserine has been bumped up by the WHO into category B drug. If you're going to formulate a long regimen, you should try to use all 5. But remember, not all TB drugs are created equal. And it is the group A drugs that are mandatory, but if you can't give them, you can't leave them out. You need to substitute at least 2 Cs in their place. So you can't just go, patient's anemic, I can't give linezolid, I'll just give without linezolid. If we do that, we will lose bedaquiline. Bedaquiline will become, resistance will be acquired to bedaquiline, and in South Africa we're already seeing resistance developing. It's in a small population group, it's not a cause for panic, it's all under control, but someone's laughing, no, not a cause for panic. But if we don't protect these 3 drugs, then we're going to get further resistance, and we'll get this thing called TDR, totally drug-resistant TB. We don't want that. So they're not equal, and if you've got to substitute, you've got to substitute at least 2 drugs. What are the drugs that we can substitute? Those are the group C drugs. Ethambutol, our old friend, I don't think it does any good, but I don't think it does any harm. PZA, so delaminid is the other new kid on the block, but please never confuse the 2. Bedaquiline saves lives. Delaminid has never been proven to save lives. It reduces the time to culture conversion by 11 days. That is not significant. So it's a useful drug. It's got a novel mode of action, but to me it's a lot like ethambutol or whatever. PZA, I don't know if you've seen the resistance patterns to PZA in your community, but it's at least 50%. And it is not logical to give a drug to which there is resistance. So I don't know why it's still there, but it's still there. Imipenem or the carbapenems, they are very difficult to administer. Although they're effective, we have to give them through a port usually, because it's an intravenous drug for at least 6 months. It's expensive and also in Cloud Cuckooland, I think. Amikacin remains on the list, and please note kanamycin, capreomycin, and streptomycin can be used if you've got proven sensitivity to it, but amikacin remains on the list. Kanamycin is gone. And then we've got ethionamide and prothionamide, horrible drugs. They look a lot like INH, they cause lots of side effects. And PAS, there's almost no resistance to PAS, but it's a very difficult drug to get someone to actually be able to adhere to. You're supposed to tell your patients to buy yogurt. Many of my patients cannot buy yogurt. Yogurt is expensive, and we're telling them to buy something to counteract the side effects that is beyond the reach. So where did this information come from? Why did the WHO come up with this? There was a pivotal paper published in September 2018 in the individual patient meta-analysis. About a third of the patients were contributed from South Africa, which is why bedaquiline got bumped up. And they looked at successful treatment. To a certain extent, they looked at failure or relapse, but that's not always captured by the program. We call someone successful at the end of 9 months and then kiss them on both cheeks and send them home. And the programs often don't document relapses. And in this cohort, 14% of patients died. And then, so quickly take notes, because, okay, only joking. This is what the tables look like that they generated. So what they did, and I'm not a statistician, is they tried to pick out the individual effect of each drug. So they looked at ethambutol, they looked at each drug and tried to decide whether it contributed to success and whether it contributed to failure. I just want to pause a little bit and talk about the method that they used. So I picked one of the drugs on the table, and the drug that I picked was ethambutol. And for the first time ever, they looked at whether the drug worked in patients with proven resistance or not. Before, we just had this one-size-fits-all, like a pair of socks, and we just gave it to everyone. And even if someone had documented ethambutol resistance or PZA resistance, we just said, well, we've got no options, we're just going to give this drug. And for the first time, people actually looked at whether the drug works in the presence of documented genotypic or phenotypic resistance, which is a little bit after the fact, but nevertheless. And then what they looked at is they looked at whether the addition of ethambutol to a regimen ended up in causing success or death. So it doesn't, please note that relapse and failure are, failure is unsuccessful, but relapse is not recorded here. And they had a look at all of the patients that were given this regimen, and they looked at the contribution of a single drug. And we looked at two things, or the WHO looked at two things. The first one was, does the drug contribute to success? And it was calculated with an adjusted risk difference. Please don't ask me how it was done because I'm not a statistician. But if it was below 1, then it doesn't really contribute to success. And then the information for death is the opposite. If it's below 1, it contributes to death. So below 1 in the death statistics were bad. And the first thing that they looked at, and why we've dropped the injectable agent, is they looked at which of the injectable agents worked. So we have streptomycin, and streptomycin is an old drug, but also a drug that hardly appears in our program anymore, because if you've got a gene expert that we know is rifampicin sensitive, we don't have a retreatment regimen. So streptomycin has been removed. Is it removed from your program as well? So streptomycin is gone. So although it might be interesting that it works, it's not all that relevant to what we do. And when we have a look, we can see that streptomycin and amikacin contributed to treatment success and didn't contribute to treatment failure or to death. In contrast, kanamycin and capreomycin both contributed to an increase in adverse outcomes, unfavorable outcomes. So if you were given, particularly capreomycin, you were more likely to die because of the addition to the drug than because of withholding it. And the reason for that is capreomycin causes potassium wasting. And we all know that your heartbeat is dependent on potassium. If you drop your potassium, it can be immediately life-threatening. So both kanamycin and capreomycin have been removed from the treatment of drug-resistant TB. And the only one that really remains in any form of, in any useful way is amikacin. We've had to redesign the STREAM trial for the 10th time. I think it's on version 10, because in the light of this, we can no longer use kanamycin in an injectable regimen. We need to change it to amikacin. A bit of a pain, but there it is. So, outside of the standard short course, when can you use amikacin? The first is if you've got resistance to an injectable, you shouldn't use it. So you need drug sensitivity tests to confirm susceptibility. Our populations are different, but of our 15,000 cases in South Africa that are initiated on treatment, 1,000 of them are resistant to both the injectables and quinine, are full XCRs. So if a drug resistance regimen is not going, if a drug is not going to work, particularly a drug like this, we need to exclude it. The line probe assay is a good way of excluding injectable resistance, better than for the quininones. So we need to know for sure that it works. We need to be able to monitor our patient's hearing properly. As I say, if a patient tells you they can't hear, that horse, she's bolted, it's gone. You will, the patient will have permanent hearing loss. So you need to be able to monitor audiology. And the STREAM trial has a reasonable form of testing and hearing in terms of the, what's it called? Shoebox. It's linked to an Apple app, and it's reasonable. I think it will screen out quite a lot. And then you need to watch the patient's hearing. Hearing loss occurs at about month 2. So even on the standard short course of 4 months, you can get established hearing loss. And audiology services are difficult to get hearing aids. Not all adults can tolerate hearing aids if they lose their hearing. And cochlear implants are just way too expensive. You should give the treatment for as short as possible. The shorter regimen, we know it's only 4 months, and the longer regimens, the older longer regimens, are 6 to 8 months. Streptomycin we can give if 2 conditions prevail. The first thing is if you can find it. It's almost impossible to find. And the second thing is that you can prove that that it's going to work by drug sensitivity testing, and that is not contained in the line probe assay. So what the line probe assay tells us about injectable excludes streptomycin. So if you're going to use it and if you can find it, you need to have a phenotypic test to tell you that it will work. Linezolid contributes significantly to treatment success. If you are given linezolid, you are more likely to be successfully treated. And it also contributes to a reduction in mortality, which is why it's been bumped up to a category A. Any questions so far on what I've presented? So how do you see the guidelines going in Uganda? What do you see the way forward? Any clues? Anybody from the National TB program?
So if they can't comment, I can say what we are trying to do.
Okay.
So we've had several meetings trying to revise the guideline. We have a draft which has NTLP and partners we have put our hands off. But in summary, what has been recommended, I think is as broad as South Africa. We have recommended a fully oral regimen as the first option for all the patients, and retained the injectable regimens as options. But in addition to it being fully oral, we are also intending to roll out a short oral regimen, modified short regimen in operation research mode. So the revisions are actually very good, but yeah, that's what we think. But we also think our patients should not get injections anymore. I think that's the bottom line. And we're moving a step, I think, ahead of everyone, say even giving a short oral regimen ahead of the results. So NTLP, if they are listening, if there's anything I've misrepresented, please forgive me. That's how I understood it.
Remember, this is a conversation. No one's signing on the dotted line, so it's okay.
There's no ink yet.
Yes.
There's no ink yet.
There's no ink yet.
Your random, for you to come up with that, those guidelines, you did an RCT trial.
No.
You did a random clinical trial.
For which guidelines?
For the current 2019.
Give this man a belt.
Yeah.
You know how it goes. This is the correct thing. No, we don't. We didn't. So I don't work for the WHO, so I can't speak for them. But the individual patient meta-analysis was not based on a randomized controlled trial. It was based on countries submitting their data to the WHO, and then it was analyzed in McGill University, I think, in Canada, and then they used the information from the program, and the guidelines are not based on a randomized controlled clinical trial. So that's one of the things we've got to do, is we've always got to run this kind of parallel process. STREAM was started in 2011, and the results were published in 2018. So that's a 7-year delay. And it's not, there's no criticism of STREAM. Please can I be 100% clear. But randomized controlled clinical trials take a long time. When you get an idea, from the time you get an idea to the time that the protocol is actually approved is usually about 2 years. Because it's got to go through a bunch of regulatory authorities. And when we're doing randomized controlled trials, we do need a protection. We can't just do what we want. We need it to be properly reviewed. Then you have to set up the trial, you have to monitor the trial, then you've got to get all the results in. How do we know? Have some water, please. How do we know if someone is getting better from drug-resistant TB? What are our markers? Thank you very much. How do you know if someone is cured from drug-resistant TB? Sustained culture conversion. So someone who was culture positive, becoming culture negative, and remaining that way. So, and those two cultures need to be separated by a minimum, according to the old guidelines, a minimum of 30 days. So how long does it take to tell if a culture is negative? 6 weeks. So midget culture is probably a little bit shorter, but it takes a while. So it's not like HIV. HIV, we do a viral load, and we can get the answer tomorrow morning if the labs work fast. So I can tell you whether someone's on successful antiretroviral therapy. If I can get a viral load, I know the answer immediately. So it takes a long time to get the answer. And then once we've got the answer, we need to watch our patients to make sure they don't relapse. They don't get the same infection again. And if you don't treat TB, you can get a culture conversion. If you don't treat it properly, you can actually get a culture reversion or a relapse. So the same organism you'll find again. So the nature of clinical trials in TB is much slower than in HIV. It just takes a far longer time to get an answer. So we've got to run these two things in parallel. We want randomized controlled clinical trial evidence. And I'm committed to getting that. But at the same time, we can't sit on our hands and say we've got a drug that saves people's lives and not do anything with it. We've got to implement. And I like the idea of your operational research. So people who started on the modified short course all oral, you're going to collect all the data on them. How old they were, HIV status, what their outcomes were, so that not this year, well not 2020, but 2021, we will have outcomes on those. And you will present those to the WHO. And the WHO will go, oh, yeah, right, this could work. So we need to run the processes together.
The second question I want to ask is, have you can that regimen still work on something like possibacillary TB? Now that's TB that has been disseminated within the blood system.
So that's not the definition of paucibacillary. Paucibacillary means you don't find the TB in the sputum. So when you look at the lab results, and paucibacillary, I suppose, okay, so I'm looking at the question slightly differently. Generally, paucibacillary or smear negative TB occurs in the children. It occurs and it occurs in HIV infected individuals because they're not coughing it up, or very early on in the disease process. So when you've just got a little bit of TB and you've just opened up one or two cavities. So, but what you're saying is, in someone who's got disseminated TB, will this work? You know, the TB research agenda is like 100 years out of date. Until very recently, and I'm not using the term lightly, the way they could diagnose TB was looking down a microscope to see whether we saw the organism or not. And MOT, Mycobacterium other than tuberculosis, if you look down the microscope, it looks exactly the same. So it was based on really old tests. And the only measure that we have, believe it, in 2019 of whether TB is working or not, is culture conversion, or smear conversion and culture conversion. So how do we know if someone has got beta, if they've got disseminated TB? How do we know? So if you can't find it in the lungs, does it mean that it's out of the brain, it's out of, well, it's not really in pericardium, it's out of the bone? How do we know whether someone's got beta or not? We don't. We rely on that old thing called clinical acumen. So if you see someone with TB, lymph nodes in the abdomen, splenomegaly, if that's TB, I'm not always sure that it is, you don't really know that they've got beta. We don't have a biomarker to tell us. What we do have is the patient beta. Have they gained weight? Are they not getting fevers anymore? The place where we just diagnosed it, does it look like there is less TB? So would it work in disseminated TB? Not for 9 months. If someone has got TB all over their body, we need to be treating them for far longer. And what we've done in South Africa is we've separated extrapulmonary TB into complicated versus uncomplicated. You know, nodal TB, so TB lymphadenitis, just a couple of lymph nodes in the neck. That's not severe extrapulmonary disease. That's minor extrapulmonary disease. Whereas TB in the bone marrow, in the bone, in the brain, that is complicated extrapulmonary disease. Don't know how to tell you when you've got better, but 9 months is probably not enough. We probably need 18 months of the same drugs. Any other questions? So it's exciting times, guys. Fasten your seatbelts. Things are going to change. So what I've talked about is a history where we came from, and I hope I'm also stressing that the need for research is pressing. I know that often doctors are divided into two groups, the research doctors and the implementing doctors. And the implementing doctors think that the research doctors do nothing but play on their computers. And the research doctors think that the implementing doctors are reluctant to change and that they don't want to see new things. So there's these two divisions. But in actual fact, it doesn't matter whether you work in the program or research. Our ultimate goal is to eradicate TB, to stop TB. And there are lots of arms to that, but the only way we can stop TB is if we've got effective treatment for drug-resistant TB. Of course, there's the vaccine and drug-sensitive TB and early diagnostics and all that stuff that goes with contact tracing. But one of the arms is if we're going to stop this TB epidemic, we need to stop NDR TB. And we're getting close. I'm going to retire in about 15 years, and when I retire, people will not know what NDR was. We've got good drugs. We've got good possibilities. Now what I want to do, and I'm using this last section of my presentation to really talk about, strangely enough, nanezolid. I want to present to you the results of the Nix trial. Has anybody heard of Nix? Nix was an incredibly innovative, forward-thinking trial. It was conducted in South Africa and sponsored by the Global TB Alliance. The Global TB Alliance is based in Wall Street, close to your office, and they're almost like a drug company, and they've developed a number of drugs. And we started looking at this trial, Nix-TB, in 2015. It was conducted only in South Africa. And what we wanted to do was to look at the most difficult form of drug-resistant TB, which is extensively drug-resistant TB. So there's, by definition, resistance to both quinolone and an injectable. So quinolone injectable, ionates rifampicin, and frequently when you look at the patients with XDR, they're resistant to ethambutol, PZA. PAS might work, but we've got a very limited amount of drugs that we can use. Unfortunately, South Africa has got a significant burden of extensively drug-resistant TB. But let me tell you about this trial. Let me tell you the story. So the next trial started in 2015, completed enrollment in 2017. 109 patients were enrolled, and it's overseen by the Food and Drug Administration in the United States, also the South African authorities, but there are issues with that. And we enrolled 109 patients with difficult to treat TB. Remember I told you the first outbreak of extensively drug-resistant TB, almost 95% of people died. Take a guess. Let me tell you the story and then we can guess what the results were. So the way that it worked, the way that the next trial worked, is that we screened patients with XDR TB or poorly or intolerance or treatment failure to NDR. And then it wasn't a randomized trial, it was a single arm study. And the reason for it, and it's easy to look back in hindsight, was that we didn't have treatment for XDR. We used what I term the kitchen sink approach, is that we just threw everything at the patient that we could. We used every drug that we could in the hope that something would work. And it didn't work very well. When the study was conceived, the success rate of XDR TB in South Africa was 20%. So 80% of people were unsuccessfully treated and most of them died. And they also were a source of infection. So what we did is that, although it wasn't a randomized study, people were started on a 6-month regimen. Please note these are the these are the slides that we used to present to the FDA, so there are no typos in the study. So there are no mistakes. So all the things that you are seeing is true. It's a 6-month regimen of 3 drugs, which I'll describe in a section. If they didn't get better, if they hadn't culture converted by 4 months, we had an option to extend. And then we followed them with culture every month for 6 months, and then every 3 months for thereafter. 3 months, all oral regimen. The reason it was designed as a single arm study was, of course, that we had no other options. We had no standard of care. Of course, things have changed. And you can't randomize someone to a 6-month all-oral regimen versus an 18-month kitchen sink approach with capryomycin, clofazimine, linezolid, anything you want. So it was a single-arm study. It was conducted only in South Africa for a number of reasons. We've got 1,000 XDR patients, although the number is decreasing. We've got good sites. I didn't write the site, so it says excellent investigators. I didn't write it. We've got a good infrastructure, good trial infrastructure. We've got a good regulatory environment. And prior to this, we had a rather poor outcome. And what we wanted to look at was this new novel drug called protominid. Protominid is in the same class as delanid. It's a nitro-imidazole. It's called protominid because it's named after the capital of South Africa, Pretoria. So that's a true story. It's called protominid. It's an all-oral agent that is given once a day only. So it's much easier to take a once-a-day regimen. And that was combined with bedaquiline. Bedaquiline as per its current label, which is 400 milligrams for 2 weeks, and then 200 milligrams Monday, Wednesday, Friday. And then, again, there are no mistakes on this. We used a dose of linezolid of 1,200 milligrams, which is an exceptionally high dose. But remember, we had a condition where about 80% of people didn't make it. So we wanted to hit early and hit hard. The primary endpoint of the study, so when we first measured success, was 6 months after treatment had stopped. So most patients were treated only for 6 months, and at the end of 6 months, they were decided whether they were favorable or unfavorable. Of course, unfavorable outcomes include death, if they relapsed, if they had clinical or radiological evidence of failure or bacteriological evidence of failure. The inclusion criteria were the following. I'm not going through the whole list because then you will all fall asleep. But the inclusion criteria is you have to have documented evidence of either Nix-TB or treatment failure of MDR, documented either by culture or molecular tests. Our patients needed to weigh more than 35 kilograms, and they had to have a chest X-ray that was consistent with TB. And I'm not sure what that means, because anything from a destroyed lung on one side to a mild infiltrate in the right upper lobe is consistent with TB. And in fact, even a normal X-ray is consistent with TB. Patients who were HIV infected were included because I won't participate in a study in South Africa if they don't include HIV infected patients. I'm not interested. But there was a cut-off of a CD4 count above 50. So if you had a CD4 count below 50, you were excluded. And that's because it's below 50, there are a whole lot of other things that can contribute to mortality and morbidity, and we wanted to separate those out. Some drugs were excluded, like SSRIs, antidepressants, although those are not commonly used. And of course, you can't give efavirenz and bedaquiline together, so we had to swap out our patients' antiretroviral therapy, depending on if they were on therapy or not, and use whatever was available. Major exclusion criteria, obviously anemia is an exclusion criteria when you're using 1.2 grams of linezolid, and then any decrease in any of the other cell lines like platelet count or neutrophil count. Patients had significant liver problems, they were also excluded from the study. We screened 143 patients. A number of patients failed screening, either because of anemia or because of a low CD4 count. 109 patients received the drug. Everybody was included in the safety population, and some were included in the intent to treat. I think the last Nix patient took the had their 24-month follow-up, either this month or last month. So not everybody was included in the intent to treat population. I'm going to show you the demographics. So the demographics of patients enrolled on the Nix trial, they were 35. So that closely resembles the population that's enrolled in the national program. South Africans get drug-resistant TB, median age 35. So yes, they're children, yes, they're elderly patients, but that's where they keep. Generally, more men are diagnosed with TB than women. I'm not sure why. I've read some thoughts, but I think it might be occupational exposure. So there was a slight predominance of men. Most of our patients were either black or of mixed race. and they had a BMI of about 20.6, with the lowest being 12.4. Very, very skinny, yes, and I can see your face. You're going, what's this 41? That was a patient of mine who was a diabetic. Diabetes predisposes you to HIV infection. So there was a big range, but it middled out over 20, which is not too bad, all things being considered. Most of the patients were enrolled because of an XDR diagnosis. Half of our patients were HIV infected, and some of our patients had had a current TB diagnosis for more than a year, so they were being treated. My patient, I'm just going to pause here for a second, the 141 months, that was a patient of mine. He was a young man that was diagnosed in a different province from where I live, and he'd been on and off TB treatment. He'd been adherent to his therapy, but he was diagnosed with XDR when he was 17. And he would culture convert for a little bit, and then he would relapse. Well, not relapse, the treatment wasn't adequate. And he was sick for 8 years before he came to us. And when he came to us, he was enrolled on the study. He's now been off treatment and successfully treated. It's now 36 months, so he's completely healthy. Lovely story. The other thing is half of our patients were HIV infected. Many of them had been HIV infected for quite a while, for up to 5 years, documented. And disease was moderately severe. Most of our patients had had previous TB treatment. It's interesting that there are a couple of patients that didn't, and those were contacts of Nix patients. So one sister got enrolled, and then her sister at home got sick with TB and was found to have XDR TB, so she went straight onto Nix and didn't have any previous exposure. And that's another important thing. Extensively drug-resistant TB, multi-drug resistant TB is transmissible. So it doesn't mean that you've been naughty, that you've been non-adherent to your therapy if you get drug-resistant TB. That's what I was taught as a medical student, that you earned your drug-resistant TB by not taking the medicines. It's not true. Certainly not true in South Africa. I can't remember the last MDR patient I saw that got the MDR because of non-adherence. They got their MDR in a taxi, at church, at school, from grandma. So it's a transmitted disease. So, but fortunately we've got better diagnostics, so we're finding it better. Okay, now take a guess at the success rate. What would you be happy with in this population? Half HIV infected, sick for a long time. If you know the results, don't say. But if you don't know the results, 40%. So we've got a 40. Anyone want to raise on a 40? 50. So if you were the principal investigator of this trial, you would be happy if half the patients were successfully treated. I agree. That's what I was going to be happy with. I signed on as the principal investigator. I would have been happy with 50%. Young people, half of them I would have been, if I got half of them through, I would have been happy. But this is the result. Almost 90% of our patients were successfully treated. So they had sustained culture conversion. At 6 months, and now almost 109 of them have completed 24 months since follow-up. And almost 90% of them were successfully treated. Does it matter whether they had treatment failure, or whether they were XDR? Not really, it was the same. We had to analyze by 2 ways, but either way that you look at it, 9 out of 10 patients who were treated on the Nix protocol were successfully treated. That's brilliant. I was very happy with this result. So when we looked at, if we have a look at the power, so was that 90%? Was it mainly HIV negatives or mainly HIV positives? Makes no difference. The only thing that's important with HIV, and I presume I'm preaching to the converted, if someone is going to survive their TB, if they've got HIV, HIV has to be treated. So you need adequate antiretroviral therapy. There's no debate about that. So provided you've got good antiretroviral coverage with good drugs, and we always use triple therapy of whatever form, outcomes of NDR, of XDR in this protocol were exactly the same. So we term this the BPAL regimen. bedaquiline, predominant linezolid. 90% of patients were cured. They converted to a culture negative status, and this is still holding even 24 months from initiation of therapy. So we haven't had a whole lot of relapses. Of course, when there's a good story, there's always a problem. And this is the problem. Everybody on the next trial had an adverse event. That's to be expected, because if you treat someone for 24 months, in 24 months, something is going to happen to you. You might get a cold or break your ankle. So everybody had an adverse event. The adverse events that were drug-related were largely manageable at the site. So I'm not a specialist. We had a cardiologist and a neurologist on call, but largely they were managed at the site. The only people who didn't finish their treatment were the 6 patients who died during the early phases of treatment. And we know that TB mortality occurs principally in the first 2 to 3 months. There are a whole lot of reasons for it. And we know that, that's the period of danger. But what were the side effects that we saw? The most common side effect we saw by far was peripheral neuropathy. So peripheral neuropathy, it starts off presenting with what my patients have told me is they say, my feet feel hot, even though they're not hot. And sometimes I even have to take the blanket off my feet and the medical term for this is paresthesia. So they feel something that's not real. That's not, it's not like they've got a hot water bottle on their feet. If you leave a patient on a drug that causes peripheral neuropathy, if you leave them on the drug, it's progressive. I don't see many old doctors in the room, but remember statidine. If someone got peripheral neuropathy on statidine, it was relentless. It just got worse and worse and worse. It's a similar kind of pathology. So
there are no old doctors?
Sorry? You are young, but the rest of you are young. So you think the statidine was so? So did I. Of course, we saved lives with it, but it's been shown to be it's got a high side effect. Of course it did. So there's nothing. But you young ones don't know what we went through. When I started working in HIV treatment, everybody who got HIV died. We had beautiful young people, moms with 2 or 3 small children. Didn't matter what we did, they died. We gave them cotrimoxazole, we gave them fluconazole. Now, if somebody dies from HIV, it's because they haven't come to our service. We've got excellent medications. We can stop transmission with the medications, and we can stop the progress of the disease. So we've been through 20 stormy years with HIV. And now the life expectancy is almost the same, positive versus negative. So it's a good story. But, so, back to NDR-TB. The most common side effect occurring with linezolid is peripheral neuropathy. It's relentless. Once it starts, it will progress. And it ranges, in my observation, from the patient saying, I've got pins and needles in my toes, all the way to the most severe one that I have seen was a guy who is unfortunately a truck driver. And he no longer has sensation in his feet, so he's had to be medically boarded. He can't feel anymore, so he can't drive a truck anymore. So it's a range. But as you roll out linezolid as part of your national program, this is something you have to bear in mind. The way we diagnose peripheral neuropathy is that old medical school thing, listening to what our patients have to say. If they tell you that they are developing peripheral neuropathy, they are. And you start off by examining for sensation, vibration, sense and reflexes, but we've got to keep a very close eye out on that. Then nausea and vomiting, that occurs in virtually all treatment. And the next most common side effect was nausea, was anemia, with headache, but then I think everybody gets headaches. So what could we do with this regimen? We had bedaquiline, predominant, and we gave linezolid in very high dose. If the patients dropped their hemoglobin, drop their platelets, which shouldn't occur very often, or drop their neutrophil count, we had an opportunity of either stopping it altogether, reducing the dose, and then even reducing the dose from 1.2 to 600 down to 300. And we could alter the dose of linezolid. We couldn't alter the dose of bedaquiline and protomidate. So we had flexibility in the way that we managed, but the patient had to take at least a month's worth of linezolid at this particular high dose. Treatment interruptions were common. When someone presents with liver dysfunction, you don't know what's going on, you don't know what's causing it. So in that case, we had to stop the entire regimen and then work out what was going on. 2 patients developed the criteria for Hy's law. Hy's law is a combination of bilirubin and AST/ALT, and it tells us if someone is going to go into liver failure or not. 2 patients developed the criteria for Hy's law. Both of them, once their liver functions had settled down, we reinitiated them on therapy, and both of them were cured. So it's not really a liver toxic drug. But linezolid was the driver of adverse events. It was the problem child. 50 patients, we either had to stop their treatment, interrupt it altogether, and then resume it, or resume it at a lower dose. 33% of the patients had their last couple of months of treatment on 2 drugs only, bedaquiline and protomidate, and yet they were successful. And 34 patients had so 34 patients could tolerate a dose of 1.2 grams. I don't know what the markers are of who can tolerate it and who can't. So it doesn't appear to be weight related. Because I've had some skinny, tiny little patients that have taken 1.2 grams. And I've had some big patients who can't manage it. So we don't know enough about the toxicity, but we need to watch out for it. When do the side effects occur? And I think that this is useful as you're embarking in Uganda on the use of linezolid. So this was a tightly controlled clinical trial. So we watched our patients very carefully, and I think you get a lot of information from that. But peripheral neuropathy didn't really occur in the first 3 months. There were no other drugs that we gave our patients that could contribute to peripheral neuropathy. They, of course, didn't have INH, they're resistant to INH. The antiretrovirals that we used, we would use either a protease inhibitor or navirapine, but the nucleosides was either abacavir or tenofovir. They don't really give you peripheral neuropathy. So that was the system that we used. And the peripheral neuropathy in all of these cases, the doctors attributed linezolid to be the primary cause. It occurred at about 3 months. Some patients tolerated the dose for 6 months. Some patients could hardly make 3 months. But remember, as you're rolling this out, peripheral neuropathy is something you roll this out for. It's disabling and sometimes doesn't recur. The next potential side effect of linezolid is optic neuritis. To go blind is a significant adverse event. It's a significant disability. So of the 109 patients, there were 2 patients who developed optic neuropathy. We had access to ophthalmologists, so we could refer our patients. But both of these patients, one was in my site and one was in Durban, they came to us and told us they had they had optic neuritis. They told us that they couldn't see because they couldn't see the TV. They said, I sit in my armchair, I'm looking at the TV, and I didn't see Bafana beating Egypt. So they complained of a difference in visual acuity. We checked it up. So at every visit, we did a simple Snellen's test, 6/6 vision. And if they had a decrease in their vision, then we referred them to an ophthalmologist. Only 2 cases had documented optic neuritis. But listen again to what your patients do. You're incorporating a visual acuity test, but if the patient complains of decrease in vision, they're right. So you need to stop their drug. Both of these patients, they developed between the 4th and 5th month. We stopped the drug and their vision has returned back to normal. So you just need to keep an eye on it. If you don't look for it, then your patients will lose their sight. In terms of myelosuppression, so the most common form of myelosuppression was anemia. And again, a patient with a hemoglobin that's low, it's not uncommon. Often the treatment of an anemic patient with TB is TB treatment. That's the treatment. And then you find that as their weight increases, so does the hemoglobin. You don't need hematinics, you might treat other infections, but it's generally the TB itself. Anemia was much more common than neutropenia. And there were 5 cases of thrombocytopenia, so decreased platelets, and none of them were grade 4. So it's anemia that we need to watch out for. And what you need to do is you need to, even if you don't have access to a full blood count, which I know is often difficult in remote areas, but at least you need to get a measure of someone's hemoglobin, and you can use those hemoglobinometers. They're okay. If they're done properly, you get a reasonable idea of what someone's hemoglobin is. I'll leave that one out, but when did myelosuppression occur? It would tend to occur in the first 3 months. So if you can get someone over the first 3 months of treatment, then they probably are going to be okay from a myelosuppression point of view. I'm not saying don't check their hemoglobin, but the principal effects of myelosuppression occur early on, and that makes sense because your bone marrow is a rapidly dividing area. So if we're going to get mitochondrial toxicity, it's going to occur early on. So watch out for a drop in hemoglobin, watch out for peripheral neuropathy. But remember, linezolid is a group A drug, which means that you need to fight to get your patients on it. I'm not talking about fighting the regulatory authorities, or you need to do as much as you can to get your patient on the treatment. South African doctors can sometimes be a little bit nervous, and if someone's hemoglobin is 8.2, they don't want to give linezolid. Patients with low hemoglobins and NDR-TB, they should hopefully be in hospital. Hopefully we can watch them if you've got beds, and watch them very closely. But you'll often find that their hemoglobins just pop up because you're treating their infection correctly and then watching for any other problems. So this is a major breakthrough. And now Nix has got a baby sister. Her name is Nix, and we're looking at optimizing the dose of linezolid. 1.2 grams is too much. 600 milligrams is probably all right. 300 is too low. So we've got to find the correct dose of linezolid. And I predict that in 4 or 5 years' time, that this will become the standard. When we've got the correct dose of linezolid, that we'll have a single fixed dose kind of Nix-TB that is either a 600 milligrams or a 300 milligrams or something of linezolid, and you can swap it out. But this is a very nice regimen. If you count up the number of tablets that it is on a week beyond the first 2 weeks, it's 23 tablets a week. Some of our NDR patients take 23 tablets a day. So we're now reducing the pill burden, and this is going to be the way of the future. So, as I was saying at the meeting this morning, don't sign those guidelines with permanent ink because things are going to change. And we need to be flexible to the accumulation of new evidence for the treatment of our patients. In summary, and then I'm going to take questions, is that we need to do research in this area. It is a violation of people's human rights for us to not know what the best treatment is for a condition. And we need to run the 2 research agendas together. We need to do randomized controlled clinical trials, but acknowledge that randomized controlled clinical trials take a long time. And also their selection criteria for randomized controlled clinical trials. If a patient walks into your office, and maybe this doesn't happen in Uganda, it certainly happens in South Africa, with drug-resistant TB and they smell of alcohol, what do I do as a trial clinician? Exclude. What do I do as a program physician? Treat. I have no choice. So I've got to work out a way that I can support this patient's adherence, and maybe decrease the amount of alcohol they're taking. I mean, just work out a way to treat them. I've got no choice. But in clinical trials, we do exclude those patients. So we need information from both the cohort as well as from randomized controlled clinical trials. You can hear the death knell of the injections. It is almost the end of injectables for drug-resistant TB. You know what's weird is that HIV, they want injectable agents. They're looking for injectable agents. But now we are saying we don't want injectable agents anymore. There's a combination of cabotegravir, which is an integrase inhibitor, and rilpivirine, that's an injectable agent. It's still in the experimental age, but maybe one day what's going to happen is that it'll be one injection every 8 weeks for the treatment of HIV. The patients, I think what we need to do is to have an approach to patients like we have with contraception, is that you've got a whole lot of choices. You want an injection, that's fine. You want to take pills, that's fine. You want surgical, we've got it all. So we're getting there with drug-resistant TB. And I predict that the treatment, even of 9 months, is going to become too long if we take out all the stuff that doesn't work. PZA doesn't work half of the time. Ethionamide, if you can tolerate it, probably only works in 40% of our patients anyway. So we need novel agents, we need new things. And the time of the old drugs has gone, and the time of the new drugs is coming. Is resistance going to develop to these drugs? Oh, yes. We have been given a precious gift in the form of bedaquiline, linezolid, protonamide, delaminid, clofazimide. And we need to protect them. And protect them doesn't mean don't give them, but we need to do everything we can to support our patients' adherence. So gone are the days when we can judge our patients who are not taking. We need to do everything we can to make sure that they can take the medicines, that the side effects are not too bad, that they don't have to walk 10 kilometers every day for DOT at our facilities. I mean, that's not really a tenable solution. So we need to support adherence. And then we can, already in South Africa, with the use of the newer agents, we're seeing a decline in the amount of MDR because we're cutting off one of the sources, which is transmission. Thank you very much.
That's been quite a journey. All the way from the history of MDR-TB treatment. You took us through the burden of TB in South Africa, and I saw some people squeezing their faces when you mentioned how many cases of MDR you actually have over the years. And I think it is something that we really were looking forward to, and thank you so much for coming. Join me in giving her another hand clap. So I'm not going to spend a lot of time because I know we are running out of time, but I'm going to ask for some key questions because I know everyone is itching to ask, but if we ask, we may not exactly complete all these questions in the next 15 minutes or so. But let's use the next 15 minutes to ask those burning questions that are going to inform the clinicians, that are going to inform the program people. I know Dr. Nakwagala is here. I saw him shaking when you said he's the chair for our IRB. And when someone asked whether individual level data for patients could inform a guideline, and then we set it off without a clinical trial, he will probably tell you something about that. But and he's also one of those people that treated people with D40, and so was I. I remember we used to give them 40 milligrams,
Yes.
and when they would not tolerate that, we'd give them 30, depending on the weight band, and then take it off. So I was there. I'm trying to generate evidence at an individual level. So could I invite some questions to Dr. Francesca Conradie for the wonderful work that she's done? Maybe she could clear a few things that are still not making sense in your head. I don't have a microphone to move around, so you put up your hand, and then we spot you and we ask you. Dr. Nakwagala.
A comment and a question. What we are doing in this country for public health emergencies, like Ebola, and is to be more flexible on our regulatory pathways. And so we've had cases where we've approved Ebola trials within a week of application and all that. So I would advise that we consider, in terms of our regulatory language, we consider MDR-TB, XDR-TB as a public health emergency, and then relax regulatory pathways. So what we have done as a country, we have introduced what's called joint review. So we bring together the National Drug Authority, National Council for Science and Technology, and the Research Ethics Committee in one meeting, and we do the review once. Instead of the usual go this way, go that way, then go. So if we look at it as a public health emergency, then you don't need to fear that there will be delays. Maybe the delays will come from your side, where you want the science to be so strict and all that. But I think our side we shall be relaxed.
That deserves.
No, it's not an offer for me. Sorry. For the information, yes. But a small question I had was, we know that our patients here have a lot of sensory neuropathy, TB or not TB, diabetes or not diabetes. So, and I noticed that more than 70% of the patients were blacks or Africans. And I don't know whether the neuropathy you saw was just a reflection of their being African, their being black. Whether it's a true side effect of that. Because our patients here have a lot of background neuropathy, whether they're on drugs or not. And then my second question would be, I work in endocrinology and I'm very much interested in diabetes and TB interactions. You don't have the numbers, I guess, to answer those questions, but when it comes to program, whatever, what do you anticipate to be the effect of diabetes and interaction with TB in terms of the new drugs that you're talking about?
So I'm going to answer your first question about peripheral neuropathy. So patients were excluded from this protocol if they had a grade 3 or grade 4 peripheral neuropathy. And what drives peripheral neuropathy? So what are the causes? HIV definitely is a cause. The older drugs that we used for HIV were a cause. Then other drugs like INH, diabetes is a cause of peripheral neuropathy, and then nutritional disorders can also. So patients with severe neuropathy were excluded. So all of these were new, the development of treatment emergent peripheral neuropathy that the investigators felt was due to the drugs. So I think, what do we do in a patient who already has peripheral neuropathy, say from uncontrolled diabetes? I think we need to be cautious with the use of linezolid, and we need to monitor that quite closely. But as far as possible, we need to get our NDR patients to take a minimum of a month of linezolid. I'm not talking about dropping hemoglobins to 5 and all kinds of drama like that, but I'm talking, we need to try and support as much as we can because it's a very powerful drug. They are developing newer oxynolidozones, so in the same class, but again, there's one called sutezolid, which everyone talks about but nobody's seen. It's not in clinical practice and it's been associated with the liver dysfunction. So until we've got a new one, this is the one that we're going to be using. I think, so yes, I understand about the high background prevalence of peripheral neuropathy, but, and by the way, vitamin B6 makes no difference. So you can pickle your patient in the vitamin Bs, but it'll make no difference. So, you know, don't add to the pill burden with something that's not going to work. Let's see. Let's watch your patients on your new regimen quite closely and then document it quite carefully, and let's see if there is a difference. So in terms of diabetes, there's a couple of ways that we've got problems. The first problem is that diabetes causes peripheral neuropathy, and diabetes makes you more likely to get TB. So there's a high incident rate of active disease of TB in a diabetic patient because they're relatively immunocompromised. Then, if the patients are being treated on an oral agent, there's a potential interaction between metformin and linezolid. Like there was a potential, and then it even's worse than that because there's an interaction between metformin and dolutegravir. So there's a whole lot of complications that we need to keep a close eye on in terms of drug-drug interactions and patient-level adverse events. I would urge again that as you roll out your new all-oral regimen, and I think that your new all-oral regimen is a good idea, that you document very carefully comorbidities, both HIV and diabetes, and then in a year or two's time, you will have a signal. You will be able to say, listen, we can't give this drug. Metformin can cause lactic acidosis, and so allegedly can the Nesolid, although I've not seen a proven case. So it's again something we need to watch out for. So document carefully and then add to the body of knowledge for Uganda and for the rest of Africa and the rest of the world.
Okay. I hope Dr. Napa got some. Okay.
Thank you, Francesca. For me, these results that show the BPAL regimen for 6 months have shocked me a lot. 90% is the 40% ahead of the global achieving outcomes of about 50%. But it's very promising because it shows that there is light. I could appreciate this study with XTRTB in Lira, in the panel meeting, and it's a red flag for us because what are we going to do with the patient? So there is hope. I also wonder, the success of DRTB therapy is based on DOT. The medicines must be swallowed and they must stay in the stomach and do their job there. In Uganda, we have a mixed mode of care. We do both inpatient and the ambulatory care, where they go to a facility near their homes, to a nearby healthcare worker to do the DOT. But the DOT is not happening the way it should be. So how did you do it in this BPAL study? Did you admit your patients with DRTB to ensure that there was DOT in a controlled environment, or were they given these drugs in the community?
The short answer is they were given them in the community. So it started off when this regimen started to be used, that everybody with XDR-TB was admitted. And then you don't need DRT because it's nurse administered. But and then they were discharged from our facilities when they had sustained culture conversion. So they were usually discharged at 3 or 4 months. I didn't show you the full data, but people culture converted at 8 weeks on this regimen. I think the latest culture conversion was just after 16 weeks. So that's when they culture converted. And then they were discharged home. What we did with our patients is we tried to arrange community DOT. So we asked the patient if they had someone who could help them with the taking of their medicines. I have to admit that I'm a little bit of a cynic about DOT. Again, this is a discussion, and I'm not saying this is my opinion. So caveat, Francesca thinks, not this is what the WHO and anyone else thinks. Is that often DOT is a burden to the patient. I am employed and I have a personal vehicle, which means if I had to go to the clinic every day to pick up my medicine, I would be all right. But I'm not the average person who gets MDR-TB. Most of our patients don't have their own transport. It costs them money to get to the clinic, and therefore you're making the situation worse and you're kind of punishing them. And if you're going to do DOT, I think that the best thing to do is to arrange it so they can either be in the patient's home, or we can adopt the model that we've used in HIV. In HIV, I tell my patients, you are HIV infected. This is an incurable disease, however, it is easy to treat. If you swallow your first set of medicines, either a dolutegravir or an efavirenz-based regimen, you can be on this treatment for the next 20 years. If you miss tablets, resistance is going to develop. So we give shortening adherence counseling down into a couple of sentences. And if you ask the average HIV patient, they will usually know what their CD4 count was. In South Africa, they'll know what their CD4 count was when they started. They will know what their latest viral load was. They will know what medicines they are, and they will protest to make sure that they get their medicines. They won't have a treatment interruption. So every now and then we run out of medicines like any country. So we need to adopt the same kind of mentality with TB. And that is to inform the patients about their condition. I know that, especially with drug-resistant, drug-sensitive TB, people go, gene expert rifampicin resistance, here, take this medicine. And no one tells them that rifampicin makes your urine look like orange juice. Has anyone taken rifampicin in this audience? It looks like orange juice. And patients worry about that. If we just in the beginning said, when you go to the loo, you're going to see that your urine is yellow. And if you cry, your tears will be stained yellow. It would help with adherence. So we need to adopt a kind of a flexible approach where we are not punishing patients for getting drug-resistant TB. What we are doing is assisting them to take medicines. Why do patients not take their medicines? Why are patients non-adherent? If you tell your patient to take a medicine and they don't take it, why? Sorry?
The benefits of adhering to their treatment.
Yes?
And they may struggle with the side effects.
So the first one, if they don't understand the benefits, that's our fault. If we can't explain to someone why they should take their medicines, we haven't done our jobs properly. And I'm taking responsibility onto ourselves. If you vomit every day from the side effect of ethionamide, look, I would give up. I had morning sickness, and it was horrible. For 4 months with my last baby, I vomited at every ward round. I excused myself. So it's a terrible side effect. So if people aren't taking their medicines because of side effects, we need better medicines. Not say you have to take this. And as you say, if you don't swallow it and it doesn't stay in your stomach, it ain't going to work. So we've got to get better side effects, medicines with better side effects, side effect profiles.
That is Dr. Susan. She's the head of the TB unit, Mulago Hospital.
I did not finish.
Oh, you have no
Yes, thank you. So about the you did mention that the 2 patients who got osteoarthritis was reversible. Yes. And then those that got peripheral neuropathy, it was irreversible.
No, it was mostly reversible. There were some cases that had peripheral neuropathy that persisted even at the end of the treatment. So most patients, what happened is that when they started to complain of pain, we looked at their clinical outcomes. So if they had culture converted, we're on month 5 or 6 of treatment, we just stopped it. So they ended up on 2 drugs only. And most of the patients had reversible peripheral neuropathy.
Now, neuropathy is very uncomfortable.
Very.
It is so uncomfortable. So how many patients had disability due to the neuropathy?
Of the
They
109,
couldn't function normally. They couldn't
Yes.
do their work or sit among people or behave. Yeah.
1. So 1 patient had irreversible peripheral neuropathy. The patient I told you about that was a truck driver. And that was also dependent on his profession, but the bottom line is he lost sensation in his feet. The vast majority of patients, because we were hyper-vigilant for it, and we looked for it, and when they told us it was there, we decreased the dose or stopped the treatment altogether. Only 1 patient had persistent. But it's the same as with stavudine. If you kept pushing on it, you got lactic acidosis and deaths. But when the patient came to us when they were on stavudine all those years ago, if they told me that they were vomiting and they were losing weight, that was lactic acidosis until proved otherwise. It usually was. So we need to, it's a core drug, it's not a negotiable drug, but it's also a drug with a side effect profile that we can't just put out in the clinics and hope it's going to be fine. We need to actively pursue the side effects. And when they occur, we need to manage them appropriately. Remember, in the next trial, we were just ordinary doctors. I'm not a specialist. We didn't have a neurologist on call, we were just ordinary doctors. And we could manage all of the side effects at our level.
Okay, okay. Let me take Dr. Levy here. He's the resident epidemiologist at TAFE.
I do. You probably know much more than I do about statistical methods.
So thanks, Francesca, for the presentation. At least you taught us and as the learning medics were able to follow treatment of MDR. I got concerned with DPAR and its efficacy of 90%. And I had a feeling that did you do something unique that probably is not done to the standard treatment that we can attribute probably some of this purely to that kind of intervention, or it's purely due to DPAR? And if that is true, in our setting in Uganda, would you recommend this DPAR, or you think another CT can be done to prove it, to provide more evidence of its efficacy to our setting in Uganda?
Yeah, so yes and no, to do something special. So clinical trials always have inclusion and exclusion criteria. So someone who reeks of alcohol was excluded. Patients with very low CD4 counts, or patients who told me they didn't believe that they had TB, it happens, or that God was going to cure their TB, they were excluded. So clinical trials are a kind of a rarefied, it's not clinical practice, it's clinical trials. So yeah, there were exclusion criteria, and also we had a lot of staff. At my site we had between 2 or 3 doctors, most of them go off on maternity leave. So we had 2 or 3 doctors, we had 2 or 3 study coordinators, we had counsellors, and we had the ability to follow up patients. So it's a rarefied example. And then your next question was?
No, I was wondering if it's evident enough to have DPAR treatment recommended for in the Uganda setting, or we need to do a trial to prove it with the standard.
Yeah, so not with the standard, because there is no standard. So that MEPI regimen has become the control for XDR. So if you're going to treat XDR, this has become the control. And we need to check the linezolid dose, so there is another randomized control trial. But what the TB Alliance wants to do is to start using this regimen carefully within communities under a compassionate access program. So compassionate access means before it's registered by your authorities, but so it can be used, but in a very controlled environment. And in South Africa, we are hopefully going to start a compassionate Nix regimen at controlled sites quite soon. And then kind of it will sort itself out, because we have to enroll more patients, and while we watch for side effects, we get kind of the more regular patients like you see, and we are seeing.
So my watch is saying something different from what that clock is saying. But I'll only take 2 more questions, I think, and then we can close. I'll ask the director of the institute to be the last person to speak and wrap up the day. So let's get a question from one of our guests, and then, no, we had a gentleman, now the lady.
Thank you very much, and thank you, Francesca, for this wonderful presentation. Mine is an experience from the patients. When the patients come to us and we tell them about all the things, they say they want something at once. And so at this point, from the mixed trial data, the stream results, the WHO regimen, it looks like all the things work. So is it possible for us to give the patients an opportunity to select from what is available and not make a decision then? And so they can say that, well, you told me about all this and I'll go with this. So is that something that we can do? And the other is that I've seen that South Africa, in their guidelines, they also have you included surgical management, which you haven't talked about? How does surgical management come into treatment of TB and MDR TB as well?
So the answer to whether we're at a stage yet when we can give patients a whole lot of options and let them weigh up the decisions themselves, we're not there yet. And in fact, in many conditions, we're still not there yet, not only TB. If a patient with HIV tells me they don't want to take a nucleoside, then their treatment options are limited. So, and the other thing is that when we're talking about a national TB program, it's not like going to your local pharmacy and there are 5 ACE inhibitors and 3 calcium channel blockers and you can choose. The national TB program has to procure these drugs. So we're not quite yet at that stage. Mistakes that we make in the TB program, just to balance it out, will be mistakes that live with us for the next 50 years. My father got TB in 2008. And he acquired his TB in the Depression in 1930. My dad was born in 1923. So he had an occupational exposure when he was a young man, but he presented with his TB in 2008. So whatever TB he acquired then presented 50 years later. And this is not you don't need to write this down and publish this again. This is common. So a mistake that we make will live with us for many years. So we've got to be very careful that we're treating patients correctly. Because if I'm sitting next to somebody with XDR on the bus, I may only present with my XDR TB in 10 years' time. When I get old or I develop or maybe I am old, you all think I'm old. But if I get diabetes, then I might present a little bit later. So we've got to be very careful about the decisions we make. The decisions are based on the activity of the drugs. Are they bactericidal, bacteriostatic? Are they sterilizing in their side effect profile? So we're not quite there yet. In terms of surgical management, you can consider surgical management as an additional drug. If you can take out a lobe or even an entire lung, and it's not uncommon that you see patients that keep relapsing because where their TB is hidden is in those fibrotic cavities, and as soon as you stop their drugs, it starts to come out again. So yes, surgical management is a possibility, but there are a couple of caveats with that. First of all, it's got to be localized disease. If you've got bilateral disease, you can't have surgery unless you can replace someone's heart and lungs, which is not really a possibility. So it's got to be localized, preferably lobar, but sometimes just on the one side. They've got to have sufficient respiratory reserve that if you conduct surgery on them, that you are not going to, they won't be able to have oxygen exchange anymore. So they have sufficient reserve. And then the other thing is that it's risky surgery. Surgeons, we know they're a bit nervous. So they don't like, and I wouldn't be a cardiothoracic surgeon, let's face it, because it's in dark cavities. But also the most important thing if you're going to do cardiothoracic surgery is you need good post-operative care, probably for the first 2 to 3 weeks. So you've got to be able to mobilize your patients. So it's not so much the initial surgery, but the time thereafter. But it's surgery, if you can remove a lobe that's affected by TB, then you can often effect a cure. It's got to be the last resort, not the first resort, because I'm not a surgeon. So I think it's got to be the last thing that you do, but it is an option.
Okay. So one more question from him.
Yes, thank you, Chair. I'm Paul Donald. I'm one of the study doctors in one of the studies sponsored by TB Alliance.
Yes.
We happen to use some of those drugs in our combination. We have the napion-butomide in combination with Moxie and PZ. I was most interested in the side effect profile that you gave, maybe about the peripheral neuropathy, the data that you've given, by what grading, the data that you presented, at what grade did you consider them as being side effects? Did you take all grades or you went from grade 3 and above?
So peripheral neuropathy has got a specific grading in the DAIDS TOX tables about how it affects the quality of life. But It also depends on the patient. I've got some patients, they say, no, I've got no problem, and then they've got no sensation from their knee downwards, which is a grade 4, and other patients go, oh, no, I can't manage. So we had to combine both the grading and the patient's experience, and we usually interrupted at about a grade 2. But don't worry about simplicity, it doesn't have linezolid in it. So simplicity is predominant moxifloxacin, PZA, and bedaquiline. And it's a very interesting study because it's looking at a pan-TB regimen. So it's not only looking at MDR. Are you doing MDR or drug sensitive or both?
Yeah, I think both.
Both. So that means when somebody's diagnosed with TB, if they get the BPAMZ regimen, it will treat both drug resistant and drug sensitive. So it's a very novel concept. Pretominid, the thing hanging over pretominid, and we didn't see it on simplicity, on Nix, is it's a potential hepatotoxic drug. So it's, again, we need to watch out for that, but then so is rifampicin and so is INH.
So in short, the peripheral was one of the adverse events expected for linezolid.
Yes. Yeah. It's not expected for MOXIE, it's not expected for PZA, and not for pretominid. So.
Okay, let me ask Bruce to make his comments and then we can wrap up.
Actually, most of my concerns and questions have been addressed already, but I wanted to first inform Francesca that in this country, probably in this room, there are very many people who would not mind to be staying here. Secondly, I wanted to pick on his comments. Post-bacillary TB should be treated like the other TB. If I have 200 TB and you have 50 TB, should we be taking the same drugs? So one time we were thinking like you. So this guy, they are called what, Unitate? Unitate? Yeah. They put up a call for trials. So we put up a trial where I wanted to treat people according to how much TB they had. 2 weeks, if you have little, like that. 1 month. We almost got a negative score. So the world is not thinking like that. But I'm very happy you are thinking like that. So, but we burnt our fingers, we never go back.
Just to pause there,
yes.
How do you know how much TB a patient has? What are risk factors?
Those are some of our problems. We had our score. Later how much TB, bacilli,
smears, cavities, HIV status. And even in the HREZ, we're over-treating a whole lot of patients. And we're under-treating some as well. But we've got this, I call it like socks, one size fits all. TB, we've just developed this one size fits all. And we need a little bit more of a stratified approach. The world is starting to think like Bruce.
The score was not very busy.
They almost called us to punishment. It's about this Nix trial. It's actually, first of all, I didn't say thank you very much for teaching us. It has been very, very enlightening about this changing field of MPR, which changes everything. So the Nix trial, so you have treated XDR-TB in 6 months with 3 drugs. Now, of course, I appreciate the scientists' comment that people will still want this randomized. Yeah, some people will say, no, we want it randomized. But that notwithstanding, now how do we go back to treat again just normal MDR of 6 months, with 12 months, with these results? So the implication of this, I think, but you can comment on this, not a question, but you can comment as a clinician, what do you see the implication of these results in program, in clinic? Even in your own clinic now, if you have this data, and that's actually, I think, what Susan is also tempted to start thinking. If I know that these 3 drugs treat XDR very well, how can I start continue changing 5 drugs for 12 months when I'm with my patients? Maybe you can comment on that. I thought it was not a question. Then the real question I had was, In your results, you showed on the DGT, which was at 18%.
Sorry?
There's a table where you showed people who had raised DGT,
Yes.
18%. What about the other liver enzymes? Means they didn't raise at all, or this was taken as a surrogate for the others? Thank you.
Okay, so to answer the question about the randomization, I'm about to start a study, hopefully as soon as next week, where what we're looking at is we are randomizing patients with just MDR. Well, no. Our point of entry into care is a rifampicin resistance on Gene Expert. So, and they walk in the door and we don't know what they are. So all we know, they're resistant to rifampicin. They could be rifampicin mono-resistant, or they could be XDR. And we can't not treat people until we find the answer to that. And our burden of XDR is quite high. So the study that I'm going to be conducting is a combination of bedaquiline delaminate, which is the other nitramidazole, the Nezalid, and then we're protecting it with two drugs, either clofazimine and levofloxacin, until we get the answer to that, and then we drop one of these two. And we're comparing that to the standard of care. So the standard of care is our 9-month oral regimen. If they're diagnosed with XDR, then we have various alternatives. So we're developing the body of evidence. If I enroll my first patient, I'm hoping next week Friday, we're just waiting for drug supplies. Then the answer to this question will be presented at the World TB Conference in 2024. That's how long it's going to take to enroll the patients and have adequate follow-up for us to come up with an answer. So we're accumulating substantial evidence. Hopefully the Data Safety Monitoring Board stops my study early because the new one is so good. I'm hoping, but we'll see. But the bottom line is we've got to run the systems parallel. It is premature at this stage to offer patients bedaquiline pretominate and the Nezalid at the dose of Nix in an uncontrolled environment in a clinic. And it's not the efficacy that worries me, it's the safety. We're going to get the answer in a couple of years' time, but you're right, it's a difficult line we have to tread as clinicians. The accumulation of evidence and when to put them into policy. Mistakes are going to be with us for the next 50 years.
Okay.
GGT, sorry. There were 2 cases that fulfilled Hy's law. There were about 3 grade 3 AST ALTs. One of them was a patient who died, but she also had severe sepsis. So I think it's hard to pick that one. The rest of them, we waited for their liver functions to resolve and restarted therapy, and they were fine.
So, I think we all agree that this has been an afternoon well spent, full of science, and it's always nice to talk to the people that are actually doing the things, as opposed to reading about them, and so now we feel closer to MDR than, not that we're going to acquire it. I want to thank each and every one of you that has made it here today. You've been very patient. I know it is beyond 5, but you have actually sat and you don't feel like moving. It's a very impressive show of how things are done. I hope other people will learn about this. So we have a recording. We want to also thank our partners from Ministry of Health that offered to carry out or conduct this recording, and we hope we shall be able to access it when the time comes, right? Right. Because we do archive our recordings in the Institute. So we'll probably ask for it sometime later. So allow me to finally thank the presenter who came all the way from South Africa. She's here on many tickets, but she's also a guru in community engagement. As you all know, many of the clinical trials require that the community gets to be part of the community of the clinical trial, from inception all the way to dissemination, and so utilization of the results from the clinical trials becomes a lot easier if the community is embedded into the trial and its activities from the word go. So join me to give her a thunderous hand clap. So I invite you to a cup of tea. I know it's